Hello, everyone. My name is Chris Schneider. I'm a gastroenterologist in Melbourne. Unfortunately, I couldn't attend the conference earlier today. I had to, unfortunately, attend to some clinical duties I couldn't get out of. So I'm unsure what you guys have covered so far. So I think I'm just going to go straight into the evidence on gastroenterology. I imagine you guys have heard a lot of the background already in terms of medical cannabis and its uses. So I'll just go straight into evidence in gastroenterology, and we'll talk about 5 different areas, and then I'm available for questions afterwards. So the area where it's considered substantial evidence in gastroenterology is in the area of chemotherapy-induced nausea and vomiting. It's one of the original areas that medical cannabis was studied, both cannabis synthetics, cannabis oils, as well as dried flower, are all studied in this area. There's even been studies where they've gone head to head with some of the conventional therapies, such as ondansetron, and showed an equivalency. So it's this is out of the guidelines I wrote as part of a group in Canada, and through the review of the evidence that we saw, we were able to make the following conclusion that medical cannabis should be considered in the use of chemotherapy-induced nausea and vomiting. And just like most areas, like most medications studied for like antiemetic medications, they're studied in chemotherapy-induced nausea and vomiting because you have a large cohort of patients that have nausea and vomiting, but we use these medications in all different areas, like for all different types of nausea and vomiting. So we said, based on that, we think that it's probably medical cannabis is probably likely beneficial in treating all comers suffering with nausea and vomiting. And what's particular about this is the antiemetics like amend, like apripitant, that class of medications are very effective at reducing vomiting in patients receiving chemotherapy. However, they don't always take away the nausea. So many patients stop vomiting, which they're happy about, and that's a huge plus for these patients. But they still feel nauseous all day, and it's a horrible feeling. And so the cannabis seems to be effective at controlling the nausea portion. So I think that it could be used even in combination with these very powerful antiemetics used in the early days of chemotherapy. Um, Going into a second area of substantial evidence is appetite stimulation. It's first studied in HIV/AIDS wasting syndrome. Thankfully, we don't see that as much now, thanks to the highly effective antiretrovirals. But this is an area of substantial evidence in gastroenterology. Both synthetics, dried flower, and oils were studied in this population, and it works. It improves quality life and actually extends life in patients suffering with this condition. Um, because of the success in HIV/AIDS wasting syndrome, it's been studied in other areas of appetite stimulation. One area that's a real struggle in terms of treating lack of appetite is in anorexia nervosa. And there are some small studies to suggest that there is a benefit in some of these patients. This is an area that I think it still needs to be studied under investigation, especially due to the very fragile nature of these patients and needing to, we need to tread very lightly. But this could be considered for a patient, especially when other areas have been exhausted. In terms of appetite stimulation in cancer, this is an area with a lot more robust research, not as absolute strong as the HIV AIDS wasting syndrome, but definitely an area where there's a decent amount of evidence, and it should be. We were able to conclude that medical cannabis is effective in stimulating appetite in patients and improving the quality of life in cancer patients. And so this is another application of appetite stimulation. One area we deal with lots in gastroenterology is inflammatory bowel disease. 1 in 400 Australians suffer with inflammatory bowel disease. Mainly divided up into 2 main subtypes: the Crohn's disease and ulcerative colitis. And there's a tremendous amount of interest among some researchers as medical cannabis being potentially a disease modifying drug, especially the fact that there's a large amount of CB1 receptors found in the gut, as well as the CB2 receptors found on the neutrophils and the white blood cells. And it's seen in animal models that in times of acute inflammation, there's a upregulation of the CB1 receptors. That if you block the CB1 receptors, animal models will have more severe inflammation, and that if you stimulate the CB1 receptors with a medical cannabis and agonist, you'll have a decrease in the amount of inflammation and recruitment of white blood cells. In terms of the human studies, there's been three main studies that have been done, total of 93 patients. Too early to tell right now. This is a Cochrane review, and they determined that it's still uncertain at this moment. If we look at some of the studies, this is a study that is often looked at, and there's a very similar study in ulcerative colitis done by the Israeli group. And so this one here was this one was on Crohn's disease, and it was a placebo-controlled trial with 21 patients with active Crohn's disease. So it's defined by a CDAI score of over 200, and that's what is commonly used in most inflammatory bowel disease. Like most in studies is they use a CDI score and they define as 200 and above as active disease. And these were patients that had very, very severe disease. They didn't respond to steroids, immunomodulators, or TNF alphas, which are the really expensive biologics. They were assigned to receive either a inhaled cannabis that had a specific amount of THC in it, total of 115 milligrams per inhaled dose, or placebo, where it was basically medical cannabis with the THC removed. And here's like a graph of showing the two groups. So the placebo group being in yellow, the treatment group being in blue, and you can see that that they both they both had quite high CDI scores. The placebo group a little bit higher. But after treatment, after week 2, you can see a significant decrease in the activity of the Crohn's disease in the treatment group, very little in the placebo group. Maybe this is the CBD working to some extent, and remains throughout the study. And then off the study, back up to the levels that it was before. And so this is the last bars are where they're off medical cannabis, but they're still part of the study. So the results were quite impressive. Clinical response noticed noted in 10 out of the 11 cannabis group patients, were only 4 out of 11 in the placebo group. And 3 of these patients in the cannabis group, which were steroid dependent, meaning that their disease was so severe they could not get off of corticosteroids. They were completely weaned off of the corticosteroids throughout the study. And the subjects that received medical cannabis, just like the cancer patients, when looking in appetite stimulation, report improved appetite, better sleep, and decreased pain. And then this is similar studies in ulcerative colitis. So we were able to conclude, the group that I worked with in Canada to develop this evidence-based approach is that there are promising studies, but they're limited by some of the methodology. So in these groups, it's since there was THC was an active component, it was kind of it wasn't really blinded. Patients probably knew what they were getting, and then also by the size of these studies. So it's right now, I think medical cannabis would be appropriate to be used as a symptom management tool in inflammatory bowel disease, but not as a disease modifying drug at this point. If we go into irritable bowel syndrome, this is even more common than inflammatory bowel disease. Affects 15% of the Australian population, and it's the most common referral to gastroenterologists. It's tough to diagnose and tough to treat disease because there's no specific blood test or endoscopic finding that will tell us whether someone has irritable bowel syndrome or not. It's purely a clinical diagnosis divided into three categories: IBT, I'm sorry, I'm saying IBT, but IBSD, so it's a diarrhea predominant, IBSC, which is constipation predominant, or M, which means mix between diarrhea and constipation. Lots of research going into IBS at this moment because it has a significant cost to our society. And the main sort of three culprits that are being investigated is the gut-brain axis. So that, and you do see that there definitely is an influence because people feel the symptoms much more when they're anxious or stressed. The microbiome, so it's the good and bacteria, as well as where are the bacteria, and just this year in the American guidelines, it's been recommended that we check everyone for small intestinal bacterial overgrowth. So it means too much bacteria in the small bowel, causing fermentation and bloating of our foods. And then also another big component that's being investigated and has some quite robust studies is looking at food intolerances. And that was really well demonstrated by a group in Melbourne at Monash University with patients responding really well to the low FODMAP diet. Yeah, unfortunate thing with low FODMAP diet is it's very unsustainable. It's a very strict diet, very hard for people to follow, and has some unintended consequences where people get very malnourished and even undernourished at times. So if we go, this is inflammatory, but it's supposed to be irritable. So irritable bowel syndrome, in terms of the evidence, there are two clinical studies, two physiologic studies, and then a meta-analysis. And basically the conclusion of the IBS studies that we have at this moment is that the physiologic studies show that there is an improvement in IBS-D and IBS-M, mostly in the fact that cannabis slows down the digestive tract. So if you're having diarrhea, you'll have these patients had less in those studies, as well as it does modulate abdominal pain. But further studies need to be done. And exactly what ingredient, what chemovar is really having the major effect, and what dose do we use for IBS patients? In terms of I'll just sort of skip this. In terms of trying to figure that out, we're conducting a study that's starting in August, and I'm a co-author on that with Alistair Vickery at Emerald Clinic, and it's going to be a longitudinal cohort study over 3 months with 60 patients, and we've been able to secure funding for this, as well as free product for patients. So if you do have IBS patients, you're welcome to send them to either refer to me, and we can do this through telehealth for those patients if they're out of Melbourne, and or refer them to Emerald Clinic, and so we're going to be looking at the response based on validated questionnaires, and a few and ruling out a few other underlying diseases, as well as verifying the effect of medical cannabis on the microbiome. And we're going to look at 3 different strains: in the purified CBD, in a CBD predominant strain, and a balanced strain. So that'll hopefully shed some more light into what kind of dosing, what kind of chemovar is the most appropriate for IBS patients. And then we're doing something similar in IBD, but that study is still yet to come, and it'll probably start later this year in 2020. In terms of gastrointestinal cancers, there's been studies to show evaluating in terms of pain management, and definitely there's evidence to support effectiveness in pain management in gastrointestinal cancers, as well as evidence in opioid sparing. So we feel that it can definitely be used in gastrointestinal cancers. So I think I'll just stop there. I have a whole bunch of other slides, but I really don't want to risk doing stuff that you guys have already done today. I imagine, like, I've seen the list of presenters and it's very impressive. So I'm sure many of these subjects were covered. So I was just thinking I'd stick to gastroenterology and just answer any questions and end my presentation here.
Thanks, Chris. We actually do have one question.
Yeah.
says, I would like to ask Dr. Schneider about his views on patients using raw juice cannabis for management of inflammatory bowel disorders. I know of patients who report great benefit with this.
Mhm. Yeah, I mean, I come, I arrived in Australia in 2019. My wife's Australian, but since 2016, I've been dealing with medical cannabis patients in Canada. And I've definitely had at least a dozen patients that have done that. They've used great quantities of cannabis. Mostly they had to grow it themselves to be able to get the kind of doses that they were after, and they reported a very good benefit. A lot of them swore by it. They said it was really helpful for them. So I guess anecdotally, I've had similar reports that patients have done well in it. There's been no studies to show that. It doesn't mean it doesn't work, but I mean, if someone came to me and said that's what they want to do, I wouldn't object to it. I wouldn't say, don't do it. I don't think it would be harmful to them. But I wouldn't be able to say that I could guarantee or I could support, I have evidence to support that this would be helpful. So, yeah, it's sort of in the anecdotal evidence stage.
Thanks, Chris. We have one other question as of right now, or actually a few other questions. How high is too high for THC? What is your limit?
My limit. Well, I've had some people on some mega doses in the past, so I don't really have any upper limit if they're tolerating it well and they're doing safe. In terms of effectiveness in gastro conditions, like gastro is because what's beautiful with gastroenterology is that since there seems to be sort of a direct acting effect of lots of medications. So a great example of this is amitriptyline or NDEP, that's called commercially here, is like the depression doses is 150 milligrams to 300 milligrams a day to treat depression. But for reducing abdominal pain, we use 10 to 50 milligrams at most. And so we can get away with much lower doses. So you see that with its effect on abdominal pain and slowing the digestive tract. So typically, I'll start people off at 1.25 milligrams to 2.5 milligrams a day. And most of the time, by the time they get to 7.5 milligrams to 10 milligrams, I shouldn't say a day, a dose. So, there'll be BD is what I'm typically dosing at. So by the time they get to 7.5 milligrams BD, they're definitely seeing an improvement in their digestive tract symptoms. And we don't have to go much higher. And as you guys probably talked about today, patients will typically get to a dose, they'll titrate up to the effective dose, and they'll stay at that dose. You won't see that effect that you see with opioids where, it keeps losing its effect and patients are searching for higher and higher doses. These patients are able to control their symptoms and stay at the same dose for years.
Okay, thanks. We have another question. I've suffered from IBS for most of my life due to my chronic anxiety. So full spectrum oil has helped tremendously with my anxiety, and I've dropped off multiple pharmaceuticals, yet I still suffer from IBS. Is it possible that my IBS is just not treatable since I've had it for so long?
Yeah, I mean, it's a lot of people sitting in that situation. And unfortunately, like IBS, I think it was because it's such a complicated issue. It's not really well approached and by gastroenterology as a whole. But there are lots of options. There's more and more things coming out all the time. And the microbiome modification is very exciting. There's evidence that fecal transplant works well, and that's another trial we're setting up here in Australia. So I think that I don't think it's worth giving up. I think it's reasonable to expect to have some degree of symptoms. It's very difficult to get to the absolute 100%. But I think it is. I think that I think it'd be a real shame if somebody just gave up, lived with it, and had such severe symptoms that they weren't able to. Their life was limited. They weren't able to do all their activities of daily living and social and professional activities. And so I think there's definitely probably things that could be done and further investigated. I think that, yeah, I think it'd be worthwhile continuing to work on that and look into it.
Okay, great. And we have one last question. Where does radiation cystitis or proctitis fall into the umbrella of IBS?
IBS. So yeah, so it's kind of a different modality. Like IBS, you wouldn't expect. I mean, you could have sort of both at the same time, but IBS is defined by no other clinical manifestations. So you wouldn't see, you shouldn't see any inflammation on the blood tests, the stool tests, or the scopes that you do in IBS. So if somebody had radiation cystitis or proctitis, that would be the primary diagnosis. Now, they may also have some underlying IBS that they already had before, but you would treat them differently. The radiation proctitis, you would treat it with anti-inflammatories, such as like the 5-ASA agents or sulcrafate. And the IBS, you would treat it with antispasmodic, dietary interventions, microbiotic interventions, and potentially medical cannabis.
The questions keep coming in, so I have another one for you.
Okay.
What is your opinion on TDS dosing as opposed to BD, please?
Yeah, I think I think that's very reasonable, and I think probably the person that asked that they're going off the half life of, like, if we're talking about oils, they're going off the half life of the oils. So the oils are 6 to 8 hours. So when you're doing BD dosing, even if you got 8 hours, you're not getting, you're only getting 2/3 of the day. So for sure, I've done TDS dosing lots in the past, and that's been necessary on some patients. The reason we go for the BD dosing often at the start is just so that we don't accumulate the cannabis too quickly and dose up too quickly. And also just a cost reason. But I think it's totally reasonable to do TDS dosing for medical cannabis.
All right, so I think we are at our last question. What specific products are you using for this study?
For that study, so Tilray sponsored the study, so we're using the Tilray suite of products. Probably people could probably tell based on the dosages. So yeah, so it's we're using Tilray, and I know many of the other licensed producers have similar products. So they could probably, if we're seeing a response on those, they could probably extrapolate that it would be similar response to the Tilray products. But those are the ones we're using. And then for our IBD study, we're still working with a few. There's been an expression of interest from a few of the licensed producers. We're just trying to find the right fit, to get at what we're after in terms of the chemovars we want to study. So that one's still yet to be determined. But yeah, I'm excited for that, and I think it'll be really interesting to see what we find out on this initial IBS study, and ultimately the IBD study that's coming later this year.